Get a few moments till get a full crew and we'll get going. Why don't we just get going? Okay, this is a intracardiac tracing with some surface electrocardiograms. Question posed is there anything wrong here? So, anybody have any thoughts on this?
I don't see a I don't see a his cap, or I guess that the second
That,
from the bottom
that
is
is a HIS. It says HBE, which stands for His bundle electrogram.
got it.
Sorry, it's cut off.
No worries.
Is that a first degree heart block?
Okay, I agree with that statement. Do we have any insights into the etiology of the first degree heart block? Well, what is a normal AH and HV interval in say, an adult, but probably similar in children?
An AH is like 55 to 120, and HV is about 35 to 50, 55.
That's right. So what do you think's going on here? Is this so what does the AH interval reflect on this intracardiac electrograms?
It's a reflection of the atrial conduction from the atrium to the His bundle.
Okay, that's true. But what is that? What do we believe that's reflecting, though? That's correct. That is the interval from the A to the His. But what's going on? How does it go from the atrium to the His? What structure is it utilizing to do that?
I think it reflects the atrioventricular conduction time.
Right. The AV node, right. That's right. So the AH, remember, we believe reflects the AV node. We've discussed how the AV node, interestingly, does not make an electrical impulse on intracardiac tracings. Now, one of my old mentors, Dr. Walter Gamble, who was an electrophysiologist at Children's in Boston, is now in his very late 90s. He used to say that if you had a completely electrical neutral room, you would be able to record an actual AV nodal signal. But in normal clinical practice, we cannot record AV nodal signals. We can record the low or the high right atrium near the AV node, and we can record the His bundle electrogram, but we cannot record the AV node. So we infer AV nodal conduction by measuring the A to H interval, and we infer infrahisian conduction by measuring the H to V interval. So based on Ivana's correct comments to us that the AH, normal AH is somewhere between 50 and 130 in an adult, and HV about 35 to 55 milliseconds. Is this AV nodal problem, infrahisian problem, both problem? What do you think?
The age interval seems to be within the normal limit. So that would mean that and the HV is like 95, so that's prolonged. So I would see something to do with the His bundle and below the His bundle.
Right. That's correct. And, again, when the AH is that long, though, you're right, it is at the upper limits of normal, but that's stretching it. So there's some kind of generalized conduction disorder in this patient. I'm not sure what the etiology was in this particular case, but probably I would say borderline AV node disease, definitely infrahiscient conduction disease. And we would expect that this looks like spontaneous sinus rhythm. I'm going to make a prediction that if we were to pace this patient at any kind of a rate above 100, there likely would be some form of block seen, whether at the AV node or the infrahiscient position. But this is somebody who clearly has conduction disease of some sort. Okay, good. Right. This is a download. So when people have ICDs or SICDs, we can now remotely monitor them through a device that the patient. There's different types. Some of the companies use a telephone app, so a smartphone app, and others of them have an actual device which is roughly the size of I don't know, like say 2 cell phones, 3 cell phones stacked on top of one another that they basically plug into the outlet at home, and it actually is essentially a cell tower itself, and it through Bluetooth actually will communicate with the device. Usually what happens is that they're programmed to communicate at like 2 in the morning or something like that. Patient is unaware that it's happening. However, if there is an event that occurs that is worrisome, whether it's a problem with the lead, an episode of getting shocked, an episode of VT or VF, the system will also is triggered when you're in the field of the Bluetooth. It's triggered to send the tracing as well. So this is a tracing that came through the pike that I think Jack actually saw this and informed us about this. So what do you think's going on here? This is, by the way, a teenager with a history of VF, resuscitated in the field in the past, and is on beta blockers. I should also mention this is actually nice because up until recently, you could not actually download SICDs. They could only be interrogated in the office. So only in the last year or two do we have the ability to do remote SICD checks, which is really nice. And unfortunately, a number of our patients, and I'd say most of them who have SICDs, have the older model that just does not allow for remote monitoring. So I'm sorry to interrupt. Go ahead.
So I think it started with a white complex, what I would assume is his basal rhythm, ventricular rhythm. And then he went into a monomorphic VT for about 10, 12 seconds, and then he was shocked. And then back to his beta rhythm, but there were frequent BVCs. I can see the base strip because it's covered with my zoom. But I think it was more like couplets and
yeah. Now, and it looks like monomorphic. It's hard to know. We'd have to take calibers out. Certainly, what's the rate, Mohammed?
Close to 300.
Yeah. So this is serious VT or VF even. Probably VT though, because I agree with you. It does appear to be monomorphic. Why do you think it waited like? It basically waited like 15 seconds before it shocked the patient. Any thoughts on, is that appropriate for the device? Is that an indication that there could be a problem with the device? What do you think?
I think it's a programmed feature of the device that waits a certain amount of time in arrhythmia before shocking.
That's right. That's exactly right. And that amount of time is programmable by the electrophysiologist. And typically what we would in a perfect world want is for the patient to be in the arrhythmia long enough to faint. so that when they get shocked, they don't actually feel the shock. This episode, I believe, according to the patient, was felt by the patient. So presumably they had not yet fainted. Although I think we can predict that if it had gone on a little longer, probably he would have fainted, or she would have. So based on this, do you feel that the device worked well? Do you have any criticisms of the device's interpretation or therapy and effectiveness of therapy?
I think it worked well. I would just maybe
Yeah.
I don't know what the dose of beta blocker is on, and maybe add flecainide if it's uncontrolled.
So definitely it worked. It seems to have worked well. It definitely terminated the arrhythmia. So what are we looking for when we do this? Well, the first thing we want to see is, did it get the patient out of the arrhythmia? And the answer, of course, is yes. Did it get out in one shock? Yes. So here's the shock here, and the patient is, it's definitely in sinus with, as you said earlier, some PVCs, a couplet, but definitely got out of the arrhythmia. The other important thing is, how did it sense, right? Because remember, with an SICD, there is not actually a lead on the heart. The lead is subcutaneous and is tunneled from the patient's axillary line on the left side in an L-shaped formation from the device to the lower portion of the sternum and then up along the left side of the sternum. And so essentially, the lead is almost like an ECG lead, and that's what the device is interrogating or assessing. And because of that, some patients, so whenever anyone gets an SICD, before the device is implanted, we do tests of the electrocardiogram with the leads in different positions, trying to mirror what the system would look like, would see in the event that an SICD were implanted. And typically, there are 3 different vectors that the system can see. And in order to, quote unquote, pass the test, the patient has to have adequate size of electrogram or adequate ECG QRS size in 2 of the 3 vectors. In this particular case, I think the patient met all 3 vectors, and it's very, it's very nice because if we look at the VT, there is a tachycardia notation for pretty much every single one of them. So that's a good sign that the device actually was able to sense the arrhythmia and during tachycardia, because I think that would be one of, the big concerns with SICDs is, will the sensing be good? In this particular case, there's very nice evidence that it is good. And the second concern always is, will it work? Is there, is the defibrillation threshold adequate? We test these still in the OR, in the cath lab, because it's still a novel technology. But, your test may not reflect truth. And the other thing is, or the clinical situation, it sensed VT very well. If this patient had VF, in other words, if this had continued onward and had degenerated to VF, we don't actually know if the device would sense it. We basically measure the so-called R wave. We induce something. If it senses it and shocks them out, we're happy about it. But we don't really know for sure if clinically that'll be the scenario. I've had the experience of 1 or 2 patients where the R wave was large. The sensing seemed to be excellent. Even during testing in the cath lab or the OR, sensing was excellent during a defibrillation threshold test, but then they had a clinical arrhythmia and the device was incapable of seeing the arrhythmia. And in both cases, we ended up having to list the patient for transplantation because we could not figure out a way to have the device properly sense the VF. We were not confident that we could, even with dedicated rate sensing leads, we were afraid that the patient might have an episode that was undetected and would have a fatality. So sometimes that does happen. That usually happens when the VF is very, very, very fine. And it can also be seen in very small children where there isn't a lot of myocardium, so there isn't a lot of, shall we say, muscle to cause an electrogram of an adequate size. Okay, so we're on beta blockers. Let's say, Mohammed, that since you had answered, we're already on a lot. I don't know, I'll make up a number. It's a 25-kilo child is on 40 milligrams of Nadolol or 60 milligrams of Nadolol. What would be your next, what would be some options for you?
I think flecainide can
Well,
be
you
used.
could use flecainide, but of course you'd have to be sure that the patient doesn't have something where flecainide would be contraindicated. But yeah, flecainide would be an option. Sometimes we shy away from that depending on the size of the patient. You could use sotalol. You could use amiodarone. If the patient were big enough, you could give even procainamide, which can be given in what's called procan-bid, which is a BID formulation. That's the longest acting variety of procainamide. We don't use that very often anymore for sort of two reasons. One, in order to give it to children, because the lowest dose of the BID form is like 1,000 milligrams, it's essentially not appropriate for small kids. And so you would have to give, like Proc has to be given like Q6 orally. And so it's not really practically a good medicine to give to small children. The second reason we don't use Proc very often, other than that there are other agents, is has a very large number of side effects with long-term use. So can cause GI upset. It can cause lupus-like symptoms. So it's generally we don't use it anymore. It used to be very popular. This before I was a doctor, but sort of fallen out of favor as a chronic therapy for most patients. Yeah, I mean, you could also go up on the beta blockers, but one of the disadvantages of an SICD is there's no pacing capability, and so one would have to be concerned that the patient could become too bradycardic on higher doses of beta blockers. Another option would be a stellate gangliectomy, right? You could do a left sympathetic chain gangliectomy, which is a go-to move in a lot of patients, for a lot of doctors, to sort of reduce the impact of adrenaline on the heart and the stimulus for arrhythmia. That's not done very often here, but there are some centers where that is their first go-to in a circumstance of failed beta blockade. So there are a number of different options one could do in this scenario. Okay, any questions about that?
I have a question, Dr. Paz. This is about a patient we had recently. Patient is on SICD.
Mhm.
They have baseline bradycardia, like maybe in the 40s,
Yeah.
and they were on Nadolol. They were shocked, and so we increased we increased the dose of the Nadolol, and we also added the sotalol. And
Yeah.
then when the patient was admitted, there were like these times when the heart rate went down to the mid to the high 30s. So what
Mhm.
would you do in a case like that? Would you like switch over to another medication, or what would you do?
Well, I guess it really would depend on the circumstances of the bradycardia. So, for example, if the patient is in the 30s when they're sleeping, but is well perfused and has a normal blood pressure, et cetera, then I would probably do nothing about it. Really, I would base therapy for that situation on the clinical situation. It does happen with some regularity that when you put patients on very high doses of beta blockers, they get tired. So, it's always important when you're starting a beta blocker on any patient, you have to tell the patient family that your child is going to be tired for the first couple of days. Even the lowest doses of beta blockers, in my experience, will make patients a little bit tired. In the majority of cases, patients will acclimate to the feeling of tiredness and will no longer have a problem or symptoms. But sometimes, particularly when a person is diagnosed at an older age, like a teenager, it's sometimes the case that they are not tolerant of that. And so the options would be either, if you're in the case you're describing, if the patient was on Nadolol and they're adding sotalol, one could make an argument you don't really need to be on both Nadolol and sotalol because, as we've discussed, sotalol is both a beta blocker as well as a class 3 antiarrhythmic agent. And Sotalol is actually a fairly potent beta blocker, so one could just be on sotalol at high dose, and that might reduce the bradycardia. And again, this is just, to some degree, this is style. There's no obvious definitive right answer. Another option, which I have done on a few occasions, is to put a pacemaker in patients or to upgrade them. See, the downside of an SICD is there's no pacing capability at the present time. There is actually some work being done on leadless devices that can communicate with SICDs. I think that's probably coming. But I think in the situation you're describing, that patient had was like a single ventricle, which was part of the reason why the SICD was used, because obviously placing transvenous leads in single ventricles carries a lot of risks, but the most important being thrombosis and stroke and things like that. Although we're becoming a little bit more lax about putting in atrial leads in that patient group, although again, still a risk. Transvenously, I mean. So I think that probably you would try, if it were like a patient in whom putting in a lead would be very challenging, like a single ventricle patient, you would try hard to avoid having to put a pacemaker in. You know, I really hate it when my medical therapy forces me to put hardware in a patient, but that does sometimes happen. You know, but it's an easier decision when someone has a transvenous device, because upgrading someone from a transvenous single chamber ICD to a dual chamber is not very difficult. And, you know, the question you're asking is exactly why, for example, when I put in devices for people with things like long QT syndrome, which, as you know, we try not to put them in patients with long QT, but sometimes we're forced to, I almost always will put a dual chamber system in on the theory that the patient may benefit from atrial pacing. I actually have, it's interesting, I have, in the old days, ICDs were very, very large, much larger than they are today. And so the first 10 years of ICDs, it was routine to put the ICD in the patient's abdomen because there were concerns about erosion if it were in the standard subclavicular area. And I used to work with a surgeon who would put the transvenous lead in and then tunnel it to the abdomen and place the device under the rectus sheath. It's a very nice cosmetic result because the patient would have no bulge in their abdomen, and it worked generally fairly well. But as you would imagine, extraction one day could be a real disaster, a major undertaking. Every time we do a generator change, it's very complex because I have to get a general surgeon to open up the rectus sheath and go into the abdomen to change the device. The interesting thing in that case is that patient has never had an arrhythmia recorded now in 20 years since initial presentation, now that they're on medication. So the question comes up, you know, if that lead were to break, do I need to replace the device? There's lots of that question, and I will not go into that today. But one of the reasons why in that particular case I probably would replace the device, though, is because the patient is atrially paced. About a year after we put in the single chamber device, they complained a lot about being tired. And so we placed an atrial lead in that patient, and pretty much since the time of that, patient has felt great and is basically paced 85% of the time in the atrium because they're on a very high dose of beta blockade. You know, it's whenever you're thinking about an SICD, we always are worried about the possibility that the patient will need pacing. And that could be a big problem in terms of decision making for these devices. So this is a long way of saying if somebody is bradycardic and they are tolerating it and there's no hemodynamic problems associated with it, I would probably do nothing. But if the patient, you know, had low blood pressure, was poorly perfused, didn't feel well, was fainting, things of that nature, signs of low cardiac output, then I would have to adjust the medications accordingly. I might have to change the course. I know that in that patient, Dr. Love decided to keep the beta blocker and add the sotalol. Again, it's not wrong. I'm not sure that's what I would do. I probably would have just pushed on the sotalol pretty aggressively, but the last thing we want is another shock. I mean, it's wonderful that this device was, in that patient was effective and got the patient out of tachycardia. But really, what I always say is we want these devices never to go off. It's nice to know they're there, but prefer that they never actually are used. Any other questions about this? Okay. Unfortunately, I have a 7:30 meeting, so I'm going to have to call it at this point. I hope all have a good day. I'll see you at Sinai in a little bit. Thanks.
Thanks, Bye.
Thank you.